My name is Shanbaganitila Ravishankar, a provisional counselor at the Mental Health Foundation, Australia. Today, I'd like to begin by acknowledging the Wurundjeri Woiwurrung people as the traditional custodian of the land on which I live and work, and pay my respects to them, their culture, and their elders, past and present. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each and every one of you for joining us today and attending OCD latest developments. Today, it is my privilege to introduce Jim Goodin, the Vice Chairperson of the Mental Health Foundation Australia. Jim brings not only decades of professional and voluntary experiences in education and mental health, but also a personal understanding of OCD, having previously served as the president and secretary of the OCD Foundation. In his presentation today, Jim will cover historical misperceptions involving the development of the OCD diagnosis, the complexity of OCD as a condition. OCD is a complex and frequently misunderstood neuropsychiatric disorder marked by intrusive, distressing thoughts and repetitive behaviors which are performed to reduce anxiety. Such misconceptions often arise because the condition is frequently mistaken and equated with personality traits such as neatness or a preference for order, obscuring significant functional impairment. New insights into the biological and genetic underpinnings of OCD, including the growing evidences linking it with other mental health conditions, and lastly, evolving treatment approaches, including the evidence based therapies in pharmacology and cognitive behavioral therapies, as well as the development of complementary technology for self management. Today's talk is particularly important because it combines lived experience, organizational experience, research, and understanding of OCD, offering us a well rounded perspective on where we are now and where we need to be to improve outcomes for people who live with OCD. Please join me in welcoming Jim Goodin.
Thank you very much, Shabaga. I'm very happy to be here, and thank you for your very kind introduction. Okay, next slide. Okay, I want to start off by talking about the information that's currently available on the internet, and that there's more information about obsessive-compulsive disorder on the internet now than perhaps ever has been. In fact, there's more information about many types of mental health issues on the internet than perhaps there has been in the past available. Certainly, when I was first diagnosed with obsessive-compulsive disorder myself some 40 years ago, it was very hard to get any information about this condition. Now there's lots of information, but unfortunately not all of it's correct. In fact, I would say probably 70% of it is incorrect. So I want to warn people in the first instance, at the beginning of my talk, to just be aware of certain things. And the first thing is source credibility. Be aware of the source of the information that you're getting. You really need to be very careful about that, because there are a lot of people that put out false information thinking that they're doing people a favor, maybe, or some people, in fact, who are literally scamming people for their own purposes. Not everybody is correct in the information they put out there. Not all credible sources even are credible. I have heard some some people, some psychologists, for example, say things about obsessive-compulsive disorder and even very common conditions like depression that are completely erroneous and incorrect. So you need to be very careful, even of trusted sources and people that say that they have qualifications. So that's very important. Make sure that you're accessing reliable academic and experiential literature. Most important, check the references and see that it's correct and it's reputable. Even with people that might have academic qualifications, be aware that certain academics do have a bias and a motivation for putting a certain perspective on things, that their careers might be based on a certain view of conditions and how to treat them, etc. It's not always easy to check for that, but just be aware of that, and I'll give some details of that later on. Evaluate the timeliness of it, because there are updates and changes literally on a day-to-day basis in the research. You'll find that the research that I'm providing during today's talk comes from very, very recent times, 2024, 2025. And particularly be skeptical of anything that claims to, as I say, magical claims, things that claim to provide quite miraculous cures for this condition. Obsessive-compulsive disorder, certainly to the best of my knowledge, and I think when I give my history of involvement, my 40-year history of involvement with this condition, there is not a cure for obsessive-compulsive disorder. There are treatments, there are ways of controlling it, there are ways of managing it, but anybody who says that, I can cure obsessive-compulsive disorder, be very, very skeptical of anything that they say from that point on. Let's go to the next slide. So, having said that, what are my credentials and expertise to discuss OCD? Well, as I've said, I was diagnosed some 40 years ago. I have made the study of obsessive-compulsive disorder quite an important part of my life. I've been president and convener of the Obsessive-Compulsive Disorder Support Group, and still here at the Mental Health Foundation, we run an Obsessive-Compulsive Support Group. So that's the first thing. I do have postgraduate qualifications in specific areas related to mental health. I've been a reference person to Victoria Police on OCD-related suicides. I've made regular contribution to non-peer reviewed articles and essays. I'm not a scientist. I'm not a neurologist. So it's from an informed, educated lay perspective, and I want to make that clear. I'm not pretending to be a neuroscientist of any sort. I've been an organizer of obsessive-compulsive disorder forums and conferences. I regularly speak at forums and conferences, and I'm currently vice person and past chairperson of the Mental Health Foundation of Australia. So if you can put that package together, I think there's quite a bit of experience that allows me to talk with some sort of validity or expertise about this condition. Next slide, please. All right, now obsessive-compulsive disorder is characterized by 5 common symptoms. Let's start off with those. I think the most concerning are the intrusive thoughts that people have, the obsessions. And even though people associate obsessive-compulsive disorder with certain behaviors like cleaning rituals, checking rituals, rituals of symmetry and being neat and tidy and so on and so forth, people don't understand that people can be big O's, as we call them, or mainly obsessional in their thinking. You do not necessarily have to have these ritualized behaviors to receive a diagnosis of obsessive-compulsive disorder. However, it's usually the obsession that causes the behavioral traits that we associate with obsessive-compulsive disorder. And I've listed some of them: the cleaning, the obsessional checking rituals, symmetry rituals, etc. One of the worst examples of obsessive-compulsive disorder that I can think of was a lady who very typically washed her hands compulsively in her kitchen. Her hands were literally reduced to being red sores through the irritation of the soap. She had piles of soap on either side of the kitchen sink, and she really could not control her compulsive hand washing and cleanliness. And that's probably the archetypical example of obsessive compulsive disorder. Excessive worry about contamination in her case, but that contamination can go to the extent where people won't touch doorknobs, they won't touch glasses, they won't touch anything that anybody else has touched. They'll have ideas of contamination that are really extraordinarily extreme. Another can be a need for symmetry or exactness, making sure that everything is absolutely lined up on their desk, on their table, in their house in certain ways. I'm aware that former Prince Andrew, now Andrew Mountbatten Windsor, as he is called, had a need for something like 76 teddy bears arranged on his bed, and they were in order of size. Now, that might sound like a symptom of OCD. However, that's not a mistake. If that's a compulsion, if that's something that causes him great irritation, if they're not lined up in a particular order, and he's very upset, as he obviously was, with those teddy bears being out of order, you might indicate that that's a sign of obsessional thinking and the need for symmetry. I'm not sure that on the basis of that, you could diagnose Andrew Mountbatten Windsor with obsessive-compulsive disorder, but that is the sort of behaviour that is consistent with that diagnosis. The French used to call obsessive-compulsive disorder folie la deux, or the doubting illness, the doubting disease. And of course, persistent doubting and checking behaviours are a feature of obsessive-compulsive disorder. For example, a person might not believe that they've locked the door. They might go back and check maybe 20 times because they don't believe that they've perhaps locked the door properly. They believe that, oh, what if I unlocked it rather than locked it during my last visit to the door? Now, imagine somebody revisiting their car time after time, thinking, oh, did I lock it? Did I not lock it? Did I unlock it when I meant to lock it? I had a friend with obsessive-compulsive disorder who was always late to meetings because he was always checking and rechecking as to whether he had locked the door of the car. Rather various ritualistic behaviours. It might be in the shower, for example, was one of mine. I used to have a particular ritual that I would have to clean my face 20 times in a particular way. I would have to do things in terms of cleansing my body in a ritualistic behaviour. That's the sort of thing that is typical of obsessive-compulsive disorder. Checking the gas is another one. I can remember when I was first diagnosed with obsessive-compulsive disorder, the first light bulb moment for me was when the psychiatrist said, "Do you check the gas?" Well, the night before I visited the psychiatrist, I had been up all night checking the gas. I hadn't slept that night because I was up and down checking the gas all the time. So that was a real light bulb moment for me. And that's when I realized, yes, that this diagnosis of obsessive compulsive disorder was absolutely valid and true for me. So let's have the next slide, please. Now, some people claim to have obsessive compulsive disorder, and I've got a page full of luminaries here, including Leonardo DiCaprio, Justin Timberlake, Harrison Ford, Daniel Radcliffe, David Beckham, and Charlize Theron. People that say they have obsessive compulsive disorder. And you might think, well, how can such wonderfully talented, skilled people who obviously have reached the peak of their professions, how can they have obsessive compulsive disorder? Because we know obsessive compulsive disorder is one of the most disabling conditions that a person can have. Well, it's quite possible to have a low-grade obsessive compulsive disorder. And we've got to be careful when we talk about obsessive compulsive disorder, whether we're talking about, behaviors that are obsessional. It might even give you a low justification for using that term. But if we go to the next slide, please, we'll find out that there is a scale for measuring the level of obsessive compulsive behavior. And that scale is called the Yale-Brown Obsessive Compulsive Scale, or Y-BOX. And this is the gold standard, if you like, for measuring a person's level of obsessive compulsive disorder and their behavior. And as you can see, there are all sorts of levels. 0 to 4 might be quite normal in a sense. You might be very low on the scale. Don't forget this, it's kind of like a spectrum, and from least severe to most severe. So when these people are talking about that they have obsessive compulsive disorder, yes, they might well have a diagnosis of that, but only at a very, very low level. However, when you get up to the extreme level of a score of 40, for example, and who knows, beyond that, then it can be completely disabling in one's life. And I'll talk more about just how disabling it can be. One of the measures is that the World Health Organization now considers obsessive compulsive disorder to be amongst the 10 most disabling conditions that a person can have. Because when you are at the extreme end of that spectrum, a person's life is completely monopolized by the condition and dealing with it. And it will totally dominate a person's life. Let's have the next slide, please. So here's that ranking, as I said, from the World Health Organization. And as it says there from that quote, OCD is ranked by the World Health Organization in the top 10 of the most disabling illnesses in terms of lost income and decreased quality of life. Next slide. Causation. This is a very interesting area and an area of great debate within the medical and psychiatric, psychological community. What causes OCD? What are some of the factors involved? And it's not straightforward at all. And I don't think anybody who claims to give you the answer or all the answers is doing you any kind of service. They're not. It is very complicated, and certainly the research is progressing. We've made huge strides, certainly even over the last couple of years, into causation and the factors involved in obsessive compulsive disorder. But everything, as I said, is extremely complex. Next slide. Now, let's start off with some of the neurological or biological explanations for obsessive compulsive disorder, or I should say, rather than explanations, evidence of neurological impairment, because obsessive compulsive disorder is commonly considered now to be a neuropsychiatric illness. This is an area of great debate among some people, but it is labelled usually as a neuropsychiatric illness. Now, what does that mean? That means that it is actually a malfunctioning of certain mechanisms within the brain. We're not talking about how a person was raised. We're not talking about another cause. We're actually talking about some mechanism, some biological mechanism in the brain that's not working properly. Now, to the side, you'll see some scans of the brain, and they're called PET scans. And PET stands for positron emission tomography. And those scans indicate blood flow in the brain, and it can be measured. The actual living brain can be measured or photographed in terms of its blood flow and energy use. And you'll see to one side, there are certain areas of the brain that are highly active. The red indicates a great degree of blood flow and activity. And that tends to be associated with obsessive compulsive disorder. Whereas on the other side, you'll see a mainly dark or blackened area with some activity, a small little, we'll call it a map of Tasmania, like activity in the frontal cortex of the brain. And that is a normal control brain. But the obsessive compulsive brain tends to have much more energy use as measured by this positron emission tomography. And you can see that. Now, that is basically arguing or evidence that the obsessive compulsive brain is overactive. There is more blood flow, there's more things going on, especially in that highly reddened area of the prefrontal cortex. That's where all our emotional thinking and thought processes, our response to the world around us comes from. And the rest of the brain then interprets that. And we'll go into that more later on. How many people are affected by this disorder? Well, it varies. Some estimates are as low as 1.5% of the population. Generally, a figure of about 3% is usually considered correct. And the reference that I've given there is from research at Swinburne University here in Melbourne. I've tried to relate these figures to local research. That means that something like 500,000 or 500,000 people in Australia suffer from obsessive compulsive disorder. But remembering that, you have the levels of impairment and disability that I referred to in the YBOT scale, so that some people are affected to a very minor degree. Other people, it can be totally impossible for them to live a normal life. It is completely disabling. So be aware of that. When we're talking about 3%, we're talking about people who might qualify for a formal diagnosis of obsessive compulsive disorder, but to a greater or a lesser degree. Anyway, this was the very early evidence, what I'm showing you here, that there was something awry, there was something different in the brain of a person with obsessive compulsive disorder as compared with a normal control brain. One of the problems with obsessive compulsive disorder, though, is that not everybody exhibits the same biological features. There are lots of things associated with obsessive compulsive disorder biologically, but not everybody has the same features. And when I get into a discussion of the genetics, and you'll see a short video about the genetics later on, you'll come to understand why it is so complex and why people will have different biological markers in the brain, and just how confusing that can be because of the complexity of the condition. Let's have the next slide, please. Of course, there are psychological explanations for obsessive compulsive disorder, and they generally focus on that obsessive compulsive disorder is driven by anxiety. And for many, many years, obsessive compulsive disorder was considered to be an anxiety disorder. And you can see an OCD cycle there, where the person has obsessional thoughts, they experience anxiety, they have an impulse for some sort of behavior to relieve that anxiety, such as hand washing, as is illustrated there. And in washing their hands, they get some sort of temporary relief. Now, cognitive behavioral therapy, for example, might teach people that this is an obsessive compulsive disorder cycle, and to recognize it and try to moderate it themselves, to exert some self-control in understanding this kind of cycle and this kind of mechanism. And the usual way of treating that is something called exposure and response prevention. So that might be exposing the person to the obsessional thought and to restricting that compulsive behavior. So it might be very, very painful psychologically for that person to be restricted and prevented from washing their hand. You might have to work up to it gradually. You might have to say, look, only wash one hand. Only wash one hand, and only do it 5 times rather than washing both hands 10 times. And you can gradually reduce the impulse by doing that. However, in doing that, you're not actually reducing the obsession. The obsession stays, but you are limiting that behavior that results from that obsessional drive that the person has. So it's not really a cure for obsessive compulsive disorder, but it can limit the disabling nature of the condition. And it is very effective. It is very effective. At the moment, studies show that it's probably equally effective as medication in limiting some of the more disabling aspects of obsessive compulsive disorder. Let's go on to the next slide. I just do want to say about that, as I mentioned, that obsessive compulsive disorder was considered an anxiety disorder up until what was called the DSM-4, Diagnostic and Statistical Manual. Obsessive compulsive disorder was labelled as a type of anxiety disorder. It's now been taken out of that category in DSM-5, and it is now in a category of its own. So it is no longer labelled as an anxiety disorder. People understand, or medicine, psychiatric medicine, neuroscience, I guess, has now taken it out of that classification as being caused by anxiety. It is now considered something closer to a mood disorder, something more along the lines of bipolar illness, or aspects of bipolar illness in obsessive compulsive disorder. There are all sorts of manifestations of obsessive compulsive disorder, such as body dysmorphic disorder, where a person concentrates on a certain anomaly in their body. They might have a mole on their face and it causes them terrible distraction. They might think that they've got something up their nose and they're worried about it, even if it's a small lump. And they might have people looking at, I'm talking from experience actually of people that I've known in the support groups that I've run. They might have people looking up their nose to see if there's anything strange about what's up their nose. They might have some physical feature, and they become absolutely focused on it and obsessed with it, and causes some great distress. So now we accept that obsessive compulsive disorder is not purely caused by anxiety alone. Anxiety is a feature of every mental illness, and that has to be understood. Anxiety is a feature of every mental illness. And depression is also a feature of obsessive compulsive disorder. Let me say that, because you can't go through life with having obsessive compulsive disorder and not get depressed, because it is such a damn nuisance of a condition. It interferes with your daily functioning and it causes you great distress. But we now, through, as is indicated, through DSM-5 and DSM-5-TR, the most revised version of the Diagnostic and Statistical Manual, it is considered an unusual condition, and it's related to so many other conditions that it's difficult to classify. It's difficult to classify. There are so many other conditions that come in, like trichotillomania, compulsive hair pulling, which is a distinct condition. I've mentioned body dysmorphic disorder, which is a distinct condition. So many other conditions can come into obsessive compulsive disorder. There's a strong linkage, for example, with obsessive compulsive disorder and Tourette's syndrome. Many people with obsessive compulsive disorder exhibit Tourette-like syndromes of arm flapping, head shaking, involuntary movements. You might almost say that, and it has been described by Professor David Cummings in one of his seminal works, as being the flip side of Tourette's syndrome. That is, obsessive compulsive disorder being the flip side of obsessive compulsive disorder, and vice versa. So yes, very complex condition. Okay, environmental factors. Well, look, you can always blame your family and your parents for everything. You can always say, well, it was something that my parents did. They abused me psychologically. I had childhood neglect, etc. It was family stress or whatever. So it's theorized that maybe these social factors can cause obsessive compulsive disorder. I'm not a believer in that personally. I believe there are life stresses for everybody. Yes, it might be a triggering for obsessive compulsive disorder, but I don't think it's a causal factor in itself. A person has to have a predisposition, I believe, towards having obsessive compulsive disorder, and we'll get down to the genetics later. So let's look at some of the previous concepts about obsessive compulsive disorder. Okay, medieval concepts. Now, remember, the term obsessive compulsive disorder did not exist until 1903, when the term obsessive compulsive was first used in psychiatry. So when we're talking medieval times, we're not talking about an obsessive compulsive disorder, but these behaviors have existed, since human beings first walked the planet. And OCD at that time, or those characteristics that we now call obsessive compulsive disorder, were mainly viewed as in supernatural terms, or in terms of a moral weakness in some way, a religious failing, or in fact, demonic possession. Now, I have to tell you that even in this day and age, in the 21st century, there are children undergoing exorcism for obsessive compulsive disorder. I know of a very good example of a leading Australian entertainer whose son suffered from obsessive compulsive disorder and underwent an exorcism to rid himself of this condition. Now, this is outrageous in the 21st century. We're going back to medieval notions when we're talking about exorcisms. However, we did progress with Freud. Freud's contribution was the first systematic psychological theory which linked OCD to unconscious drives and early development. So it recognized obsessive compulsive disorder, and it gave a definition of it, and it gave an observation of it based on Freud's experiences. Now, if we can go to the next slide, I have a very, what would you say, confused view about Freud. I called him fraud, didn't I? Well, maybe with good reason. Because some of his notions about obsessive compulsive neurosis, as he called it, were based on some quite disparaging and well, for people with obsessive compulsive disorder, insulting notions. For example, that it was related to an anal stage fixation, and that people hadn't undergone the correct stages of development, etc. Now, it wasn't based on empirical evidence. It was based on clinical observation, patient self-reporting, things like dream analysis and Freud's other notions of id impulses and superego and so on and so forth. And while I find the notion that I may be stuck in an anal stage fixation, as Sigmund said, at least he made an attempt to understand it. Since, of course, Freud's time, which dominated psychodynamic treatments throughout the 20th century, we've progressed a lot further, and we now know that it's not a matter of being stuck in a certain phase of development. That's been completely dispensed with. Thank goodness. After Freud's time, we came to accept that there were behavioural and cognitive models for understanding obsessive compulsive disorder, that they were maladaptive beliefs, as it says there, and overestimations of threat and fear, etc. So there were purely psychological explanations. Let's go to the next slide. However, came the 1980s and the development, and particularly the 1990s, where we had the mapping of the human genome. We understood that something strange was going on with obsessive compulsive disorder, because there were all sorts of scientific developments, like the development of positron emission tomography, which I've just explained, and fMRI, which is another type of neuroimaging. And they began to show us evidence of certain, as I said in the beginning, certain dysregulation or problems in the brain. Now, some of the evidence that emerged was that there was a heritable component to obsessive compulsive disorder, that perhaps 40 to 60% likelihood that you would pass on some kind of genetic component to your children. So it does seem, and it does run in families, there's no doubt about that, obsessive compulsive disorder. So that's very unfortunate. Then we had the development of certain antidepressant medications. The early ones were called tricyclic antidepressants. One of the early effective tricyclic antidepressants was called anafranil. Anafranil was considered in its day effective, but it was a dirty drug. I have taken anafranil, and it has very nasty side effects of all sorts. And many people simply can't tolerate it because it's such a nasty drug. But then in the 1990s, we had some other medications that came along, and they were called selective reuptake inhibitors, or SSRIs, and they started to prove that they were very effective in helping and treating obsessive compulsive disorder. And especially when you combine them with cognitive behavioral therapy and exposure and response prevention, we started to have good ways of managing obsessive compulsive disorder and preventing people from experiencing the worst aspects. Let's move to the next slide. Okay, so what's new? Now, this is where we get into some really interesting stuff and some really complicated stuff, because OCD is extremely complicated. Now, as I said, I'm not a neuroscientist. However, my son is a neuroscientist, and he did his PhD on inflammatory response in depression and obsessive compulsive disorder at Swinburne University. So he's been a source of some expertise to me. Let's go to the next slide. Okay, first of all, I think I've already said, with obsessive disorder, there is a fallacy of oversimplification, putting it down to a single cause or a set of a few causes. And certainly OCD, I can't stress it enough, is not caused by anxiety alone. And there are many, many people who stubbornly hold on to that notion that obsessive compulsive disorder is an, and some of them are fairly highly qualified academics in some of our institutions in Melbourne and in Australia, and the evidence is absolutely against them. I don't know how people who hold professorships in various organisations and universities can believe that this is a simple cause for OCD, but many do, unfortunately. Let's move to the next slide. One thing that we have to understand is the chicken and the egg argument in terms of these neurological changes that we see manifest in obsessive compulsive disorder. And that means, are the neurological changes that we see in the brain, are they the result of obsessive compulsive disorder? Does it come with the condition? Does it cause the condition? Or are they a result of the behaviours that occur because somebody has obsessive compulsive disorder? In other words, do they develop as a result those brain changes of the behaviours that the person exhibits? So it's a chicken or an egg argument. My personal view is very much, and I think the evidence is very strong now, that the observable changes are neurological. They are there and that they cause the condition. That this is not a psychological condition. It is a biological condition with psychological implications. So that the person who has obsessive compulsive disorder will naturally have low self-esteem. They will naturally have low confidence. They will naturally have all sorts of psychological inhibitions, problems, complications because of this condition. It's just the same in a way as if you have one hand. You are restricted, you are disabled. It's going to cause psychological implications for you from that physical disability. Certainly my view and the evidence that OCD is now a neuropsychiatric condition is consistent with that. Let's have the next slide. Okay, I think we can miss this slide. We've already dealt with this. Okay, the mounting evidence. Next slide. So there are 5 areas that I want to talk about that are really the most recent advances in the understanding of obsessive compulsive disorder And these are the things that have occurred over the last 12 months and are being developed at the moment. And they've, as it says, significantly deepened our understanding of obsessive compulsive disorder's biological foundations. As I have said, OCD is now realized as or understood as a multifactorial disorder, meaning it arises from a whole lot of issues: genetic issues, brain-based, immune environmental factors, rather than a single cause, not just a strange manifestation of anxiety. And I've picked 5. You could pick 10, 20 different areas that OCD is being researched, in which OCD is being researched. I've picked 5 because otherwise this talk would go on for another 6 hours, I think, and I don't want to do that. And those 5 things are the genetic risk identification, secondly, the neural biomarker for deep brain stimulation, the response to that, the immune system's role in compulsive behaviours, gut microbiome's causal influence. All sounds very complicated, I'm sorry, but it is complex. And the glutamate dysregulation in neurotransmission. And I will shed a little bit more light on each and every one of those things. So hopefully make it a little bit more understandable for us all. Let's go to the next slide. So the genetic risk. Well, here in Australia, at the Queensland Institute for Mental Health, the Berghofer Institute, researchers conducted an 8-year study and have found that the genes linked to obsessive disorder for the first time, or they have discovered them, identifying 30 regions of the human genome. Remember I discussed 1990s, the mapping of the human genome? Well, this is consistent and follow on from that research, which was a huge breakthrough. 30 regions of the human genome associated with this debilitating yet often misunderstood mental illness. The research, which was published in Nature Genetics, involved more than 50,000 people with obsessive compulsive disorder and 2 million people who did not have obsessive compulsive disorder. Now, this is a little bit different if you compare this with, say, Sigmund Freud's research, where he had a number of patients, I don't know, maybe 20, maybe 30, and he used his observations to come up with his rather, I will say, outrageous conclusions. This is an objective, empirical, evidence-based scientific research at the leading edge. It's the sort of research that really needs to be done on obsessive compulsive disorder, rather than people making outlandish generalizations based on their own limited experience. But when you're talking about millions of people in sample studies, you're talking about something that can be reliably considered as good evidential work. Now, the leading light is Professor Eske Dirks, who's the senior group leader. And I think we have a video of that, and let's hear that video.
We found actual genes that play a role in OCD. OCD is obsessive-compulsive disorders, and then usually people have specific actions that we call compulsions to relieve that anxiety.
I think OCD is a hidden disorder, but it's really common. So it's around 2.5 to 3%, roughly around as common as diabetes. And it can be incredibly impactful to the point that the World Health Organization rated it as one of the top 10 disabilities in the world.
This study, we combined genetic data from over 50,000 patients and 2 million people with no OCD. We looked at millions of genetic variants, compared whether some of them are more frequent, maybe in patients with OCD. And then we found 30 regions on the DNA that are associated with OCD risk. So we can link them. And in these regions, there's around 250 genes that we can link to OCD. We found really large sharing with anxiety disorders, depression, and also with anorexia nervosa. There's a lot of overlap in the genes that cause these different mental health conditions. But it doesn't mean when you have a specific gene variant that you will definitely develop OCD.
I think it's a really significant finding because in terms of treatment for OCD, even though there's reasonable treatment response and efficacy rates, we have stalled and we really need to be looking at other areas. And what this research kind of suggests is that we can be more proactive rather than reactive and actually start looking at who is more likely.
In the future, we hope that if you can put this all together and you have all the genetic information, that if you combine them all, that we can then predict OCD risk more reliably. Of course, the genetic findings, they're exciting, but I really hope that people know these are real conditions, that if you suffer from OCD, it's not your fault. So I really hope that we can now, when we have this list of genes that are linked to OCD, that we can develop more effective treatments. We found actual genes.
Okay, now I think that's highly exciting because, as the psychologist there said, we have reached a kind of a stall in treatment of OCD. And that's why I'm introducing these very, very new findings and possibly new avenues for treatment for obsessive-compulsive disorder. But the genetic findings, as Professor Dirks has indicated, really do give us a lot of insight into possibly predicting who might be vulnerable and who might not be vulnerable. So that's a huge step forward. Let's move to the next slide. All right. The second is an indication is the biomarker for obsessive-compulsive disorder. Now, there's something called neural periodicity, and it refers us to the predictable rhythmic patterns of brain activities. And these biomarkers are measurable in people with obsessive-compulsive disorder. There's a new treatment called deep brain stimulation, which I'll talk about later. And basically, the treatment is inserting something like a pacemaker into the brain, similar to what they do, and this would be extremely severe cases of obsessive-compulsive disorder, similar to what they do with Parkinson's disease, people who are really at the end of their tether with Parkinson's disease and they're shaking all over the place, and it controls that shaking. So this method of treatment actually can control the obsessive-compulsive disorder in extreme cases. But we're talking about neurosurgery here. We're talking about a very profound kind of intervention, and not many people would be eligible for this. But nevertheless, something that actually can be inserted into the brain to neurologically rectify some of the symptoms of obsessive-compulsive disorder is important in what that represents, that this can be controlled by a surgical intervention. Pretty barbaric. I'm not suggesting that everybody rush out and say, hey, I want some deep brain stimulation and electrodes inserted in my brain. But from a purely scientific point of view, it is extremely relevant in terms of future treatments and understanding of obsessive-compulsive disorder. Let's move on to the next slide. The immune system's role in obsessive-compulsive disorder. I need to explain. There is a theory called the corticostriatal thalamocortical circuit, or CSTC for short. And you'll see a picture of the brain there, and you'll see a kind of a feedback loop starting at the prefrontal cortex and going through an area called the striatum into the thalamus and back to the cortex. Now, I'm not going to go into the details of that. People can look it up on the internet if they wish, but there's a theory with obsessive compulsive disorder that's borne out by neurological studies, neuroimaging techniques, etc., that this circuit somehow is switched on in people with obsessive compulsive disorder, and it doesn't self-regulate. In other words, it doesn't switch itself off. It doesn't naturally abate. We don't have an off switch in the normal way that most people do. So that's some interesting evidence. I can't go into it in too much detail here because it really is more complicated than either I'm capable of explaining or you can present in a short discussion like this. But there's a lot of information about this dysfunction on the internet in reputable sites. So please, if you're interested, look at this CSTC circuit and the network that regulates thoughts and actions. Remember, our thoughts primarily are believed to start in the prefrontal cortex, and the regulation occurs through the striatum, thalamus, and then back to the cortex, which interprets the thoughts and feelings. And we don't have an off switch with obsessive compulsive disorder. This is the theory. Let's go to the next slide. All right, now something that's really come up in recent time, and I'm very, very happy that we here at the Mental Health Foundation have been paying attention to this for a lot longer than it's been recognised by much of the scientific community. And that's the inherited gut microbiome causal influence. Now, I've got a picture of a dear friend of mine, Professor Felice Jacker from Deakin University, who is Distinguished Professor of Nutritional Psychiatry and founder and director of the Food and Mood Centre at Deakin University. And we often have Felice talk to us, or one of her staff members talk to us about this connection. The gut and the brain are very closely connected in terms of the moods. You know that when we have a sore stomach, we don't feel very good. It affects our mood. Well, this is a little bit more complicated than that. The gut bacteria can actually cause an increased risk of obsessive compulsive disorder. Now, this can be a genetic factor too. This is one of the genetic factors that the professor was talking about earlier on. Some people are born with certain gut mechanisms or bacteria that do not prevent the kind of inflammation that may be involved in obsessive compulsive disorder. Now, this is exactly the material that my son did his PhD on, so I'm very interested in it, that obsessive compulsive disorder can be as a result of certain inflammation, and the gut bacteria that are responsible for limiting that inflammation are less dynamic, are less able to do their job in some people than other people. That's a very simple explanation for it. But this has an effect, and it may well have an effect, as the diagram indicates there, on all sorts of mental health issues. And we're talking about bipolar disorder. We're talking about anxiety, depression, eating disorder. We're even talking about schizophrenia and post-traumatic stress disorder. That there might be a lacking in some way in gut bacteria that can contribute to these conditions and allow inflammation to occur within the brain, within the body, that can cause these conditions, or maybe a contributing factor. So how complicated this obsessive compulsive disorder stuff gets. It gets very complicated. Let's go to the next slide. There's another factor, and that's glutamate dysregulation. Now, what is glutamate? Glutamate is a neurotransmitter, It's an excitatory transmitter. In other words, it causes all sorts of interesting things to speed up within the nervous system. And some of those things may be believed to be factors in obsessive compulsive disorder. So it's now being experimented to try and prevent this glutamate from bombarding the synapses and making that transition, as you can see in the diagram, that movement, bombarding and causing this excitatory neurotransmitter to overload the synapse. It seems to be a factor in obsessive compulsive disorder. It's being researched at the moment, particularly in America. There's a drug called riluzole in America that is now approved by the Food and Drug Administration there. And it's mainly an Alzheimer's drug. It also is used for certain disorders, movement disorders in particular, like Parkinson's disease and so forth. And it has been allowed in the treatment of that. However, there's another variety called troriluzole, and that has not been approved by the FDA. You can't get it in Australia. So it's something in the future that may come, and it will limit the movement of this excitatory glutamate across the synapse. And it does seem to have some benefit, apparently, for people with obsessive compulsive disorder. So once again, another interesting area for research. And we're talking about very recent research, as you can see from my reference there, from the Journal of Affective Disorders, 15th of June, 2025. So this is very recent research, very early stages, and we're talking about experimental medications. And we're talking about very complex processes here. Let's go to the next slide. So summary. If you put all these findings together, they strongly support the hypothesis that OCD is not predominantly a psychological condition, but a complex neurobiological disorder influenced by our genetic makeup, our brain circuitry, immune mechanisms, bacteria, all sorts of things, which is exactly what I said in the beginning. So, and as I said, there are certainly psychological implications that need to be treated and are highly effective in the treatment, but it is a very, very interesting, misunderstood condition. And we're starting to realize just how misunderstood and how many numerous factors are involved in this condition. Next slide, please. Okay, having said all that, I've alluded to some of the exciting new treatments coming soon. Everything's coming soon in obsessive compulsive disorder. You know, we hope. I've spoken about deep brain stimulation. Apparently it works for some people with the most extreme obsessive compulsive disorder. And you can see the figures there. That something like 50% of patients demonstrated a good and sustained therapeutic response. Many did not. It's basically like a neural pacemaker, just like the pacemaker that you put in people's hearts, and there's an electrical rhythm that keeps the cardiac muscle pounding away. This deep brain stimulation is similar. It goes into a similar part of the brain as is involved in a similar operation for Parkinson's disease, and it does seem to regulate the most extreme forms of obsessive compulsive disorder. Now we're talking about a really end of stage treatment, but some people, this will give you some idea of just how severe the obsessive compulsive disorder can be for some people. Next slide, please. Now, an interesting one is transcranial magnetic stimulation. This is taking off like a bit of a firework. In fact, this is an actual ad from an organisation that has numerous clinics around Australia called Neurocare. So this is an actual advertisement from Neurocare. And this is what they say. They say fast antidepressant effects without medication. Basically, it's where they put a very high-powered magnet over the affected area, or the area that they believe is affected, and most likely to result in some sort of resolution of the obsessive-compulsive impulses. And they transmit a strong magnetic impulse through that area of the brain. And then they say if medications, therapy, or lifestyle changes haven't worked, TMS therapy offers an evidence-based, non-invasive solution for depression, anxiety, OCD, and other mental health conditions. Well, I don't believe that's true. I don't think it does offer a solution for anything. It may be a complementary treatment, and anything that, for some individuals, if it works, it works. Okay, go for it. But these clinics are springing up all over the place in Australia. And what it does, it regulates those or what it's claimed to do is to regulate those irregular brainwave patterns that we saw earlier on in that very, very complicated chart of periodicity and brainwave patterns. So that's the claim. Whether it works or not, the evidence is still coming in. Let's watch this space, but understand that these clinics are springing up all around Australia at the moment as we speak. Very interesting. I can't make a comment as to whether certainly what they say is not true. They can't say that this is a solution. It is not a solution. But certainly these clinics are springing up, and if you have severe OCD, give it a try. Give it a try. See, it might work for you. But I don't think the evidence is there at the moment. That's my view. Let's go to the next slide. Okay, now, the main treatment for obsessive-compulsive disorder. And remember, we're talking about the Y-box scale once again. So once you reach a certain level on that Y-box scale, then you're likely to have pharmacological treatment. Below that level, you're likely to have cognitive behavioral therapy or exposure and response prevention therapy. Once you get above a certain level, you'll have medications and you'll have those psychological interventions. The best treatments involve both. The best treatments involve both. So let's look at those medications. As I said, one of the earlier medications, as I was down the bottom, 2 tricyclic antidepressant, anafranil. And that was very, very effective, but it had terrible side effects, terrible side effects. Then in the 1990s, we found new medications. The first one was fluoxetine or Prozac. Then we had fluvoxamine or Luvox, then sertraline, then paroxetine, then citalopram, and then the one that seems to be most commonly prescribed at the moment for people with obsessive-compulsive disorder is citalopram or Lexapro. A very good medication, very few side effects. They all focus on the serotonergic aspect of neurotransmission, so that they actually regulate serotonin in the synapse of the brain. Now, there's another one that's recently been introduced. It's the most recent antidepressant that's come onto the market. Recent in the sense that it's been 10 years since the antidepressant medication prior to this venlafaxine or Effexor came onto the market. It's slightly different. It's not only a selective serotonin inhibitor, but it's also inhibits the uptake of norepinephrine, which is another neurotransmitter. And it is called an SNRI, venlafaxine. Now, I have to say, I've had venlafaxine, and I found that it was ineffective. For me, the medication that I use is Lexapro, and I find that, having previously used fluoxetine, but for medical reasons I can't take fluoxetine anymore, but Lexapro I find highly effective, but venlafaxine had no effect. So I'm just saying that for obsessive compulsive disorder, my personal experience, don't always go by one person's experience, but I'm just saying my personal experience is that it was not effective in treating my obsessive compulsive disorder, whereas Lexapro is very effective. A key point I want to make, if you go to a GP, they will give you the medication to the manufacturer's recommended maximum. So for example, fluoxetine, the recommended maximum is 20 milligrams. Unfortunately, with something like obsessive compulsive disorder, you very often need 60 to 80. That's 3 or 4 times the recommended maximum dose. Generally speaking, a GP will not go to that extent. A psychiatrist will. A psychiatrist will. It's part of their training, their understanding that you very often need a much, much higher dose for obsessive compulsive disorder to tame the effects of it than you do for depressive disorders. So just remember that if you are suffering from obsessive compulsive disorder and you're prescribed something that's 3 or 4 times the recommended maximum dose, as it says on the package, don't be terribly alarmed. Talk to your doctor about it. Talk to your psychiatrist about it. Let them explain to you that you generally need a much higher dose of that antidepressant than you do for treating depression. And as I say, GPs are far less likely to do that than what a psychiatrist is, because, you know, they're the experts in this area. I recommend that anybody who has obsessive compulsive disorder, if you're seeing a GP, that's great, but take it one step further. Make sure you see a GP, get a referral to a psychiatrist, and get a referral to a good psychologist that has experience, clinical experience with obsessive compulsive disorder. Because there are some out there that claim that they have experience and they know absolutely nothing. Let's go to the next slide. Okay, I've mentioned exposure and response prevention. I don't think I need to go on to that anymore, other than to say you can see a very nice little cycle there. You've got the obsessive thought causing anxiety. You break the compulsion some way. You know, wash your hands 10 times rather than 20 times. You know, you can wash them every hour, but not every 30 seconds. Okay, and you can gradually train a person and reduce that level of anxiety. You'll still have the obsessional thought. You'll still have the obsessional thought, but you won't have that behavior. Let's go to the next slide. And a very good friend of mine who I brought out, actually, would you believe, to Melbourne, the first OCD conference in 1992, I believe it was, Jeffrey Schwartz, Dr. Jeffrey Schwartz. He's produced a book called Brain Lock, which I would like to give a plug. Free Yourself from Obsessive Compulsive Behavior. Now, Jeffrey is a psychiatrist, but he's put together a psychological stratagem, if you like, for dealing with obsessive compulsive disorder. And I personally use this. And I see this as very, very valuable. And coming from Jeffrey Schwartz, I recommend it. He's a very, very reputable expert in obsessive-compulsive disorder. Have a look at this. Keep this slide. Get the book, Brain Lock. I don't get any royalty from it. So just by the way, I want to tell you that this is only for your benefit. And step one is relabel. Recognize that the intrusive obsessive thought and urges are the result of your OCD. Okay, this is not me. This is my OCD. This is something other than myself causing this obtrusive thought. I'm not having this terrible thought that this child is going to get run over by a car, or that this terrible thing, whatever it might be, is going to happen, or that I might do something terrible and embarrass myself or someone else or hurt someone, you know, as a result of my behavior or my action. This is not me. This is my OCD. So it's like taking a part of yourself out and transferring it and saying, no, it's over there. I'm here. You stay away from me. Don't come and invade my person, because this is certainly the sense in which OCD feels. It feels like you are under attack by your own brain. So this is Jeffrey's mechanism for saying, no, look, separate it from yourself. Try to do that as best you can. Reattribute. Realize that the intensity and obtrusiveness of the thought or the urge is caused by OCD. And it's probably related to a brain chemical imbalance. So all of a sudden, you're taking all the guilt away from yourself. You're not weak. You're not possessed. It's not your fault. Really important second stage. Thirdly, refocus. Work around the OCD thoughts by focusing your attention on something else. Do something else for a few minutes. Do another behavior. I have all sorts of strategies that I do to if I feel myself getting into an obsessional mood. One of the things that I do is I put on a sleep mask with headphones in it, and I listen to a podcast. And I can't consider anything else. I'm totally locked away in that podcast. Suddenly the obsessions go. You might have something else that distracts your thinking. You might work on model aeroplanes. You might go for a run. You might do whatever. My hips are too bad to go for a run now. That's what I used to do. I can't do that now. And step 4, revalue. Do not take the OCD thought at its face value. It is not significant in itself. Don't think because you're having that thought, it's the end of the world. But look, I do recommend Brain Lock. It's an excellent book. As I say, Jeffrey Schwartz, you won't find a better authority on dealing with it. He is a psychiatrist. He understands the biological, neurological mechanisms involved, but he's proposing behavioral, psychological strategies for dealing with obsessive-compulsive disorder. So, you know, that is very, very valuable. Let's go to the next slide. And that's all, folks. That's all. I'm afraid it's been very lengthy and maybe a bit arduous, a few details there, a lot of details that I haven't been able to go into in enough depth, but it's all there for your research, and you can contact the Mental Health Foundation either to talk to me about obsessive-compulsive disorder, if you like, or you can find out from the slides that I've presented here. We're always here to help you at the Mental Health Foundation.
Thank you, Jim Goodin, for answering the questions from our audience and your excellent presentation. I'd like to take a moment to thank each and everyone for joining us today on our highly informative webinar on OCD and the latest developments. Thank you all. Bye for now.